Okay, we're live apparently. So if anyone's watching right now, if they want to just sort of give us the go ahead on Twitter or in the YouTube comment section, just let us know that you can see us. Everything's going okay. No point in us having a chit chat if no one's watching. Oh, there we go. We've got 21 viewers. There we go. So we can crack on. I'll chop this horrendous beginning off later, make us look all professional later on. Right, okay. Right, there we go. I've got confirmation, got people watching. Right, let's jump in. Okay, so by way of introduction. So as we speak, around 9% of the UK population is taking some form of antidepressant medication. In 1991, there were 9 million prescriptions for antidepressants issued in the UK with a population of 57.4 million. And in 2015, that increased to 61 million prescriptions with a population of 65.1 million. So that's a 600% increase in antidepressant prescriptions being issued with only a 12.5% increase in population size. Even more interestingly, if we take the figures from 2006, despite the fact that the number of antidepressant prescriptions issued in the UK has more than doubled, this has not resulted in a reduction in the rates of depression or suicide, which over the same period have in fact steadily increased. So rather bleak statistics. However, if we shift from the sort of the abstract and the objective to the subjective and the anecdotal, there's plenty of people, thousands, if not tens of thousands of people, maybe even hundreds of thousands, who knows, of people in the UK who swear that antidepressants were either a life changer or a lifesaver for them. So, which brings us to the main question that we're seeking to answer today, which is antidepressant medication ever useful? So, joining me to discuss this topic today is Professor Carmine Pariante. He is a professor of biological psychiatry at the Institute of Psychiatry at King's College London and a consultant perinatal psychiatrist at the South London and Maudsley NHS Trust. Also, we have Dr. Joanna Moncrieff. She's a practicing psychiatrist and a part-time academic and author with an interest in the history, philosophy, and politics of psychiatry, and particularly in the use, misuse, and misrepresentation of psychiatric drugs. So, before we jump into the thick of this, a couple of people raised this question on Twitter. I think is a valid one. I'm interested to know myself. What do you guys, both of you guys, hope to gain from having this conversation? And I'm going to throw that to Carmine first.
So for me, this is an opportunity to discuss some important questions that are obviously clinically relevant to the people that are listening to us. They are also interesting from a research point of view and what do we know about the science underpinning antidepressants and depression, and had the opportunity to discuss this with another expert in the field and showing that actually psychiatry and mental health in general as a field has a multitude of opinions, but this opinion can be debated in a civilized way and with many points that are probably more of agreement than of disagreement.
Okay, Joanna, what about you?
Yeah, I think it's important that people are able to hear the different points of view on antidepressants and the evidence behind them, and that they're able to hear those points being debated directly rather than just having one point of view presented or another point of view presented.
Right, okay. So before we dive into the questions, people, just remember that you can submit questions. So there's going to be a Q&A portion at the end of this. I'm going to be picking the questions using Twitter. If you want to submit questions using the hashtag PsychLiveQ&A, and I'm going to be picking the questions based on the popularity. So you can search that hashtag, find a question that you like or submit your own, and then like each other's questions. And the most popular ones I'll ask at the end, but I won't be referring to Twitter until the end. I'm going to try and concentrate on what's going on here. Okay, so I think before we debate antidepressants and get in the mud, get dirty, so to speak, is there anything either of you feel needs to be said in establishing a definition of what we're talking about when we actually say, when we're speaking of antidepressants? Maybe take a moment to define antidepressants, distinguish them from other psychiatric medications. Not too long on this point, but just for clarity. And Joanna, if you'd like to take this one first.
Yeah, so, I mean, antidepressants are drugs that are prescribed, I suppose, primarily for people who are diagnosed with depression, but actually they're also used in other conditions. And it's important, I think, for people to recognise they are not a single class of drug. They're not all the same. There are different types of antidepressants which have quite different pharmacological properties. So, the common ones are the selective serotonin reuptake inhibitors, SSRIs. There are some that are a little bit similar, the SNRIs. And then there are the older tricyclic antidepressants, which are really pharmacologically quite and subjectively quite different, and then there's a variety of other antidepressants. So they're a group with they're a very diverse group of substances.
Right, okay, and are we going to be, just for clarity, are we going to be sort of debating all these different types, or are we focusing just on SSRIs, or is that, I don't know, Carmina?
So I think we will probably qualify every statement, although most people, especially as a first drug or second drug that they encounter, they will be prescribed what we call SSRI, or selective serotonin reuptake inhibitors. And so a lot of the side effects, a lot of the problems, and also a lot of the data on clinical efficacy comes from SSRIs. We have similar data on other antidepressants, and I think when needed, we will be able to distinguish. I think side effect profile, for example, are different. The toxicity and risks are slightly different among different classes. So when needed, we will discuss it separately. But I think the definition that Joanna has given, but of all the broad class of drugs that are included with this term, is the correct one, and we will refer to most of them most of the time. I think that the key point to add is that there are many other classes of medication that are prescribed for people with mental health problems, and sometimes prescribed with antidepressants. And of course, again, toxicity, side effect, risks are different, and so it is important that we keep them separate. Just to give an example, antipsychotic drugs, such as the old haloperidol, or the newer olanzapine, which can be used sometimes in patients with depression, in particular circumstances. They have a completely side effect profile. They are not antidepressants, and so should not be mixed up. Benzodiazepine, like Valium, which are used also mostly to calm anxiety, and they are prescribed sometimes in patients with depression, have yet another completely different profile of side effect. And for example, they're much more addictive. In fact, there's a high risk of addiction with benzodiazepine. And again, I think it's important to separate these classes of drugs when we express risks and benefits.
Okay, Joanna, have you got anything to address there?
Can I just add to that, Danny? I would agree with that, but I also think there are some overlapping issues. So although antidepressants aren't classically addictive in the way that benzodiazepines are, they do cause withdrawal syndromes, so that they do have some addictive properties.
Right, okay, well, we're going to be touching upon the idea of withdrawal later. Okay, so for now, right, let's get into the thick of it here. Okay, so back in August last year, during a Twitter Q&A for Antidepressant Mythbusters that you participated in, Carmina, on behalf of the Royal College of Psychiatrists, one of the tweets you put out was, the old idea that antidepressants correct a chemical imbalance in the brain is an oversimplification, and we do not support this view. Then in May of this year, so Andrea Cipriani is the guy who led a recent meta-analysis of antidepressants, which concluded that all antidepressants were more effective than placebo. He appeared in a BBC program called The Doctor Who Gave Up Drugs. And this is quoting from him: SSRIs work by increasing the level of neurotransmitters called serotonin in the brain, which to me sounds dangerously close to the idea of a chemical imbalance. Then just to throw this in there, I'm going to quote Joanna as well. So this is from your website, Joanna. Of course, there are brain events and biochemical reactions occurring when someone feels depressed, as there are all the time, but no research has ever established that a particular brain state causes or even correlates with depression. So the question that arises out of this is, how do antidepressants work? What is the supposed mechanism of action? And just to leave effectiveness to one side for now, just talking about how do antidepressants work. We'll start with you on this one, Carmine.
So the chemical imbalance, it's a simplified explanation, which I think has been used mostly, to be honest, in the 80s, in the 90s, around the time of the development of Prozac and similar medications. The principle itself is not wrong. And so what Andrea Cipriani said, that these drugs increase the availability of serotonin within the communication between brain cells, that's not wrong. So we know from a variety of studies, mostly in experimental models, so if animal models or in cell settings, in the laboratory, that these drugs can increase the amount of serotonin that is used between brain cells to communicate. Now, the reason why this is an oversimplification is because we don't know how that then translates into the therapeutic effect, to the improvement in the symptoms. Now, to make things even more complicated, of course, other antidepressants increase the availability to increase how much more other neurotransmitters increase in the brain. So noradrenaline, for example, which is another molecule the neurons use to communicate. Other antidepressants specifically target noradrenaline, or both noradrenaline and serotonin, and some others have even different pharmacological action. So certainly the idea of chemical imbalance, of a single chemical imbalance, is an oversimplification, and certainly not all antidepressants act on serotonin, although of course the serotonin reuptake inhibitors do. Having said all of this, antidepressants have measurable effect on the brain. Most of the research, but not all the research, but most of the research comes from experimental models, because of course we have difficulty in accessing the brain of depressed patients for obvious reasons. Although there have been studies using imaging methods, for example, or studies conducted in the brain donated by patient in post-mortem studies, so brain that were available for research after the patient died, that have shown that antidepressants increase the number of new brain cells that are produced. There are studies showing that antidepressant treatment change the function of brain areas that are important for emotions and thinking. So, for example, areas of the brain which tends to be, which in patients with depression tend to be more reactive to emotionally salient stimuli. With treatment of antidepressant, they tend to become less reactive. So there's a variety of changes, measurable changes in the brain. Even at macroscopic level, we know some studies showing that treatment with antidepressant increase the size of some of the brain structure. So chemical imbalance, simplified version, however, measurable biological effects on the brain, and in fact on the body, and I'm happy to discuss this in the second as part of the second question, definitely measurable effects in the brain.
Right, okay. Joanna, plenty for you to get your teeth into there, so I'm just going to step out the way and hand this over to you.
Okay. So, yeah, I wouldn't deny that antidepressants have effects on the brain. but the trouble is we have no idea whether they have anything to do with any possible mechanisms that produce or correlate with depression. So as Danny said, there does seem to persist this idea that depression is due to a chemical imbalance or represents a chemical imbalance. The group in Oxford still assert that depression correlates with and is produced by abnormalities of serotonin, but there is just no research that supports the idea that there are abnormalities, consistent and specific abnormalities of any particular neurotransmitter in depression. So the research that's looked at serotonin consists of studies of serotonin receptors, and some of those studies have shown larger numbers of particular serotonin receptors in people with depression. Some of them have shown lower numbers of these receptors in people with depression, and some have shown no difference between people with depression and people without depression in terms of these receptors. There have been studies that look at feeding people on a diet that's low in serotonin and seeing whether this causes depression. There's some suggestion that it might do in people who've had previous treatment with SSRIs, but in people who have no history of depression, this does not cause depression. And in fact, if you chemically reduce serotonin, resulting in a much stronger reduced serotonin state, you end up with a state which is not the same as depression. It is indeed abnormal, but it's more characterized by hypersensitivity and paranoia and aggression than it is by the features that we would associate with depression. So the evidence on noradrenaline, which is the other candidate neurotransmitter that there's been a lot of research done on, is even more inconsistent than the research on serotonin. And actually, if you try and pin people down as to whether there really is any evidence that serotonin is abnormal in people with depression, most people nowadays will say, well, no, there isn't really. So that's the first thing to say. We just do not have the evidence that suggests that depression is due to a chemical imbalance. We are, as I said, doing something. We are making chemical alterations when we give people antidepressants, and those chemical alterations affect people's mental states, their emotions, their thinking processes, and they affect the physical makeup of the body as well in various ways. Carmina mentioned effects on brain cells. We don't know whether those are positive or negative effects, those physical effects that we can observe. Some of the mental changes that antidepressants produce may well be relevant to the effects that are reported in antidepressant studies and the effects that people who are taking them for depression perceive and experience. But there's no evidence that those effects are in any way associated with any mechanisms that might or might not be producing a state of depression.
Carmina?
So I agree with what Joanna said. I just want to make 3 quick points. First of all, antidepressants may act on mechanism, let's say serotonin or noradrenaline, which are not necessarily abnormal in the illness or not primarily abnormal in the illness, but nevertheless, by changing those mechanisms, as Joanna said, by having effects on the brain, depressive symptoms can be reversed or treated. So we don't want to immediately associate what is the first pharmacological action of the drug with its therapeutic action. Now, I also agree with Joanna when she says that we don't know exactly how we can demonstrate causation versus correlation in research. I mean, this is a problem that we have in all research, in all conditions. In fact, I would say in all research. If we measure sugar in diabetes, we don't know which is driving what. If we measure blood pressure in patients with stroke, we don't know what is driving what. In depression, I think we have some evidence that some of the effect of antidepressants reverse abnormalities that are present in patients with depression. So we know that the brain of depressed patients, there are fewer neurons. We only know this from a small number of postmortem studies. So of course, brain from older patients, but they do tend to have a smaller number of neurons. We know that antidepressants increase the number of neurons. Is it possible that these two things correlate rather than be causally related? Of course it is, but it is at least a good lead that these may be causally related. In the same way, we know that some brain areas in depressed patients tend to react more to emotional stimuli, to emotional content, or to thoughts that are sad or pessimistic. We know that if we give antidepressants, those brain areas stop acting that way. Again, is that 100% sure that means a causation effect? No, but it's a good lead. So I think we have to work with what we have, and we definitely need more research. The last final point I want to make is that, and this is about specificity, which Joanna rightly pointed out, is that depression doesn't have to be the same disorder or the same problem for everybody. In the same way, the fever is not the same problem for everybody, and high blood pressure is not the same problem for everybody. Patients who develop depression in the context of a single acute traumatic event, a violent attack, may well be completely different from patients that develop depression in the context of ongoing stressor that started in childhood, which may be then completely different from patients who develop depression because maybe they have a very strong family history with parents and grandparents on both sides suffering from depression. These are all different individual, potentially different disorders. And so I agree that we need to do more research in subgroups and understanding why not all the abnormality are present in all depressed patients.
Okay, Joanna, I'll hand over to you if you've got anything to pick up on there. I mean, I've got a couple of questions, but I'll leave mine to the end. Well,
I just want to pick up on the idea that antidepressants increase the number of brain cells. So if you give someone something that's toxic, the brain responds by generating brain cells. And it was some of the evidence around antipsychotic drugs. There was the idea that they were good for the brain and that were improving neurogenesis. And actually, it turned out that what they were doing, in some cases anyway, was increasing markers of neurogenesis, which are also increased in Alzheimer's and other neurodegenerative disorders as a response, presumably, to the neurodegenerative process. So I don't know the research on antidepressants in detail, but I would just say that, I think we need to be very cautious about interpreting that, and we can't necessarily conclude that because they produce more brain cells, that shows they're doing a good thing. It may indeed be completely the opposite.
Well, what would be the supposed benefit of neurogenesis, of new brain cells being created in someone with depression?
So our current understanding of neurogenesis, also the formation of new neurons, is that it helps learning new patterns of understanding of the environment. So from that point of view, if we use a model in which antidepressants increase neurogenesis, and by the way, I just want to reply to Joanna saying that antidepressants have a very specific effect on neurogenesis, which is quite different from antipsychotics, for example. So that's a quite specific effect of increasing the numbers, which has not been found with other antipsychotics. So luckily, at least on that, there is some differences between drugs. But in terms of the mechanism, the idea is that neurogenesis allow new brain cells or new connection between brain cells to consolidate a new way of understanding the environment. And hence, if you like, it's very similar to psychotherapy. So it helps the patient, helps the person who is suffering from depression to interpret the world in a different way, perhaps in a less pessimistic, less sad, and develop a new cognition, new understanding of the environment in a way that is more positive and allows the patient to improves in the way they feel and the way they interpret the world. So actually, from that point of view, we know that the effect of psychotherapy and the effect of antidepressant, from that point of view, are very similar. They may just be different way of acting ultimately on the same sophisticated mechanism in the brain, which actually explains why the best success you have when you give people psychological treatment or psychotherapies and antidepressants together, because that's the time where probably the two things help each other most.
Okay, Joanna, have you got anything to sort of round that point off?
It sounds very nice, but it is all just completely speculative. You know, we've no idea what these changes mean, that these changes that you see in the brains after people have taken antidepressants. And in most cases, when drugs change the brain, they're damaging it.
Joanna, I mean, this is a judgment. This is a statement. It's a judgment about the fact that these things that happen to the brain are negative. I mean, we take lots of drugs that improve our brain situation, condition, that sometimes are therapeutic, even drugs that, of course, can be helpful at times and not helpful at other times. So I think that there's a lot of evidence on antidepressant increasing. There's lots of evidence antidepressant increasing the number of cells. There's even more evidence of antidepressant shifting or helping shifting the way the patient interprets the world, which I don't think is a bad thing, it's a good thing. Whether the two phenomena are related is we are speculating, but there are, again, experimental studies or animal studies where you give antidepressant to animals, the number of brain cells goes up, and the animals benefit from a better environment. So I think it's, I agree with you, there's no proof, but in science it's very difficult to get proof. These are all important leads that allow us to continue to do research and learn about antidepressants.
So my understanding of the research on how antidepressants change people's perceptions, that's again, the Oxford group have been doing that, is that I would say it's very difficult to draw any conclusions from it at all. That they've tried to draw the conclusions that they think make sense, but I don't think that the data necessarily support them. And you say it's a judgment. Of course it's a judgment. You're making a judgment that these things are doing a positive, the drugs are doing something positive. And that's my beef with most of the research, really, is that most researchers are starting with this assumption that the drugs we give people are doing something positive. I'm not saying it's necessarily negative, but I'm just saying generally when you introduce a chemical into someone's body that they don't know, is not normally there, often some bad consequences occur.
Go on. One final point, Carmine, and then we'll move on.
Of course. I mean, I think that's the difficult conundrum that we always have when we treat something, when we give a medication. I mean, if we give an antibiotics, we have a toxicity effect on the guts. But yet, if you're saving the life of someone who's having an infection in the lungs, that's what we need to do. And I think, when we give anti-cancer drugs, we are giving literally poisonous drugs that are there in your body to kill cells. So, and of course, the threshold for giving treatment is proportional to the severity of the illness and the risk that the illness carries. Is always a call. And I agree that there may be, in fact, there are negative effects of antidepressants, and I would never want to give antidepressant to someone who does not need them, exactly for this reason. And from that point of view, I agree with Joanna. We may not know all the negative consequences of antidepressants, and I know, for example, that only through the patient's experience and accumulation of data over many years, we're now more aware of the discontinuation symptoms, the withdrawal symptoms the patient have when they stop, if they stop abruptly, and so on. So, I'm totally in favor of I don't have a judgment call. I'm not saying that antidepressant, everything they do is good. I'm only saying that, there are some good leads, we're following it, but that doesn't mean we need to give them to everybody. We only give them if patients really need them.
So I think Carmina and I would agree that when antidepressants are given out and prescribed, the main justification for using them is this body of research that shows they are slightly better than a placebo, and that we're not really prescribing them because we think they're increasing brain cells or changing serotonin patterns, because really no one is sure about that at all. It still remains very speculative. And so that's why I think this, how you interpret the placebo-controlled trials of antidepressants and whether you think they really show that they produce any benefit or not is really the key and central question.
Right, okay, so moving on. Right, so coming back to the Cipriani meta-analysis. So Andrea Cipriani conducted a meta-analysis of 522 clinical trials looking at 21 antidepressants in adults. They conclude that all antidepressants were more effective than placebo, but the benefits compared to placebo were mostly modest. Got a shout out to Neuroskeptic for that pithy little summary. So on this, Carmine, you said that, quoting you, this meta-analysis finally puts to bed the controversy on antidepressants. Then, Joanna, from your blog, there is nothing groundbreaking about this latest meta-analysis. It simply repeats the error of previous analyses. So, question that arises out of this: how effective are antidepressants? And we'll start with Joanna.
So that meta-analysis is the biggest one that's been done, and it gets together lots and lots of data from lots of different placebo-controlled trials and comparative trials of antidepressants. So comparing them against each other. And as with other meta-analyses, it shows that antidepressants come out as being slightly different. It's slightly superior, slightly better than placebo on the main measures of depression that are used. So I have a number of problems, both with the way the analysis was done, the technicalities of it, and with the way that it's interpreted. So my first quibble with that particular analysis is that it is a bit technical, but I think it's important. It looked at the percentage or proportion of people who responded according to the different definitions of response in the different studies, and compared these proportions between people who took antidepressants and people who took placebo. And there is no cut and dry definition of what a response means. That is something that the definition of it is quite arbitrary. It's never been measured against, never really been very satisfactorily compared against any clinically meaningful indicators of response. And also, it's based on categorizing the data from the depression measurement scales. So in the outcome interviews that people do after they've been on the antidepressant in the trial or on the placebo for 8 weeks or 12 weeks or whatever it is, will involve them answering the questions on a depression scale, and they'll get a score at the end of the day on that scale. And if you look at the difference in the scores between people who take antidepressants and people who take placebo, it's very small. It's only 2 or 3 points at most, sometimes even less than that. And the total score for the most commonly used scale is 54 points. And so what the meta-analysis has done is it's taken people and divided them. It said that if they score at a certain level on this depression score, then we'll consider them as responders, and if they don't, we'll consider them as non-responders. And when you categorize people like that, in that way, you can show that you increase the apparent difference between the two treatments. So that's one of the technical things that's wrong with that meta-analysis. It's categorized the data into responders and non-responders. There's no clinical basis for those categories, and it inflates the difference between the drug and placebo. And the reason I said that, sorry, we're going on a long time, I'll just stop in a minute though, but the reason I said it was no different from previous analyses is previous meta-analyses have also shown this very small difference in depression scores between antidepressants and placebo.
Right, okay, so Carmine, I'll let you take that point.
So again, I agree with Joanna when she says in our blog that there's nothing new in this meta-analysis beyond just being bigger and larger, and also having including lots of data sets from pharmaceutical companies that were not available before. So it's just bigger. Now, I agree. I was not part of the study, and I don't have any link with that research project. So I don't think that meta-analysis in itself needs to be defended or criticized in any particular way, because it, as we said before, it reports what we already knew. If you look at average changes in this Hamilton Depression Rating Scale, which is a scale or questionnaire, as Joanna says, that's kind of sum up the different symptoms the patient have before and during antidepressant treatment. If you look at the mean difference, so on average, putting all the patients together, the difference between placebo and depressed patient is small. It is consistent, so that's why I said in my comment that it put to bed the controversy, because the main controversies has been antidepressants don't work. They are exactly as effective as placebo, and that's why I think that bit is put to bed. Now, the effect that this meta-analysis, previous meta-analysis show is more. However, 2 points are important to make. First of all, if you only measure mood, basically sadness and desperation, rather than all of the symptoms that are listed in the scale, the effect, the difference between placebo and antidepressants is much bigger, One of the reasons is technical, is that sometimes antidepressants give side effect, which can make some of the symptoms worse. So for example, these scales measure appetite, but some antidepressant gives gastric problems, which makes the appetite even worse. But if you only look at the key symptoms of depression, sadness, hopelessness, desperation, the antidepressant effect compared to placebo is bigger. The other important point is that by putting together all the patients, you hide the fact that some patients respond really well, and these are the patients that, as Danny said, define their antidepressant, the experience with antidepressant as lifesaver or life-changing. And some patients don't respond at all. They basically don't improve, or they may even get worse. And some are somehow in the middle. They improve, but only a little bit, and perhaps not in a stable way. So the question is not whether antidepressants work or not. The question is, how can we make sure we know why some depressed patients respond really well? And unfortunately, there are not many. Probably, maybe about 50%, 60%, a large minority or a small majority, certainly not all of them. All the depressed patients respond to antidepressant, especially to one antidepressant only. Why these people respond so well? How can we make the other patient respond in the same way? How can we target the right antidepressant to the right person? So we are still measuring an average number across thousands of patients, because that's what basically regulatory authorities want for us to approve an antidepressant. But this is not a clinically meaningful measure. I totally agree with Joanna. The issue is half of those patients would have had a real life-changing experience. Who are these patients? How can we make antidepressant work also in the other half that don't have the same life-changing experience? These are the questions, and we don't have the answer yet.
Right, okay, Joanna, over to you, and then I've got I've got some questions of my own on this one for definite. So
on the point about the depressed mood item, I think it's really important to say this, because a few people have suggested this. So some of the studies just take the one item out of the depression rating scale that says, how is your mood, or how depressed do you feel? I can't remember exactly how it's phrased, and report the result on that item. That is going to be highly, highly subject to publication bias, because it's never the main outcome. The main outcome is always the Hamilton rating scale. And the studies that find a positive effect on that one item are going to quote it. And the studies that don't find a positive effect on that one item are not going to quote it. So it's very dangerous, I think, to put too much weight on that outcome measure. And then the point about the variation response and whether there's a subgroup of people who respond well to antidepressants, I just don't think we have the evidence to suggest that. If there was a, it would be very easy to show that in the data of antidepressant studies, that there was a bimodal response, that there was a whole group of people who had there was very little difference between the antidepressant and placebo, and then a group of people where the difference was bigger. You'd have a clear bimodal response. As far as I know, no one has ever shown that that's the case.
So I agree with both points. So let me just qualify what I wanted to say. First of all, there have been studies that they've put together studies that were published with all the data, looking at all of the items in the scale, so looking at all kinds of symptoms, and then they've done meta-analysis on this. So the publication bias is less relevant, and they have found this effect. So I agree with Joanna that we should never use a study which only measured that. I think the evidence from studies that extract the data from published studies and do a meta-analysis is more solid. Always, everything needs to be replicated, is more solid. Then sorry, Joanna, and I agree, I don't think there's a bimodal distribution. I think this is is a normal distribution with some people that respond very well, let's say 40 to 50%. Some people, even if you want to be conservative, 1/3 to 40% of depressed patients respond very well. Some patients respond less, and some patients respond even less, and some patients don't respond. I mean, this is just individual variation in the data. That small effect that we see as an average must hide a large variability, because it's not that every patient only responds a little. A lot of patients respond nothing. Some patients respond nothing. Some patients respond a little. Some patients respond a lot. It's not bimodal. And you can arguably define which is the group that responds better. But let's say even the 1/3 that has the experience as life-changing, we should try to understand why for them there is such a big benefit, and why, how we can get the other patient to experience the same benefit. I mean, I think, the clinical experience that we all have, beyond the data, which actually also says that, is that some patients respond well, some patients respond so-so, and some patients don't respond. And I think the data from the research confirm our day-to-day clinical experience. And of course, we need scientific approach to measure this. And, some people call the kind of individual patient meta-analysis, so you can actually look at what are the features of the subject. But I'm sure that, for like anything else, some people respond a lot to antibiotics, some people don't. Some people respond a lot to antihypertensive, some people don't. And it's the same with antidepressants.
I suppose one of the issues with it is, as far as I know, so I don't want to sort of use this as the only example, but this Cipriani, if I'm saying that right, Cipriani analysis, the 500 or so trials used in that only lasted 8 weeks, were 8 weeks in length. But how do we square that with the fact that, I think that the NICE guidelines suggest that people stay on antidepressants for about, is it 2 years to try and reduce the risk of withdrawal or relapse, sorry. And, a lot of people are taking antidepressants sort of open-ended as well. So I'm not sure how the studies being done support what's actually going on in the real world.
So
can I come back on a couple of points you made?
Of course, yes.
And then, because you've moved on to a slightly different thing, Danny, if that's all right, about the long-term effects, which is really important. And one of the points I was going to make, which does relate to it, is that, and Carmina would probably agree, that our outcome measures in depression trials are really not that helpful. and there's very little data on whether giving someone antidepressants or placebo or anything actually really helps their functioning, or helps people get back to work, or really it improves people's quality of life, for example. So that was one thing to say. But another thing I just wanted to say is that this point, a couple of points about there being a small effect. If the difference between antidepressants and placebo is very small, yes, that's on average. That means, yes, of course, there are some people for whom antidepressants are substantially more effective than placebo, but it also means there's a group of people for whom placebo is substantially more effective than antidepressants. That's the point of it being an average. But more important than that is that I think we need to question whether this small difference means anything at all, because as I suggested earlier, antidepressants are, well, as we all know and acknowledge, antidepressants are active drugs. People often know whether they've got an antidepressant or a placebo in placebo-controlled trials, so they're not 100% blinded as they're meant to be. And I know, as you might from being involved in randomized controlled trials, that patients are very interested about what they're getting. They're very interested as to whether they've got the real drug or the placebo, and they'll think a lot about what they're getting. And if they're getting some side effects, they'll immediately be clued into the fact that they're taking the antidepressant. Then add to that antidepressants are what you might call mind-altering psychoactive substances. They change people's emotions and thinking quite subtly for some of them, the SSRIs. I'm not saying this is a very strong effect, but they do seem to have some subtle mind-altering effects, which will be superimposed on, which will alter people's experience of their emotions. So I think, given those effects, it's not clear to me that actually there is any real difference between antidepressants and placebo.
Right. Okay. Well, with regards to the question I had about the 8-week length of the studies, if we can probably address that later on, because I want to come to the question of the problems with withdrawal and long-term use. The glaringly obvious.
Sorry, Dan, can I just say something though? I mean, is that the recommendation, of course, is to treat for 6 to 9 months. The 2 years only comes into place for people who have had many episodes of depression. So we can talk more about this, but I thought it was important to make sure that the recommendation that we mentioned should be accurate, and then we can discuss when do we switch from one position to another.
Right. Okay. Well, I mean, the glaringly obvious question for this portion of the conversation, something I addressed at the beginning. I mean, we're talking about like the technicalities of studies and things like that. This statistic of a 600% increase in antidepressant prescriptions being issued since 1991, whereas depression rates and suicide rates have either, depending on what figures you're looking at, have either pretty much stayed the same or in some cases steadily increased. That seems like a real world example of the fact that antidepressants obviously don't work. So how do we deal with that problem? Either one, take it away.
Well, I mean, I agree. I think this is evidence that that antidepressants are not working, that we give out more and more antidepressants, but the prevalence of depression, the number of people with depression out there is ever rising, however many we seem to be prescribing. I think, suicide is maybe a completely different issue. I think my view is that suicide rates are, if related to anything, related to much more fundamental socioeconomic factors, actually, rather than antidepressant prescribing one way or another. But yes, I think if you look at real world data, there are 1 or 2 studies that have looked at antidepressants and whether people get back to work or not, and they show that actually people who are on antidepressants are less likely to get back to work than people who are not on antidepressants. That they're not randomized trials, that's the problem. So they're probably confounded by the fact that people who get onto antidepressants have more severe problems. But nevertheless, these studies don't seem to show that antidepressants are actually being effective in reducing the consequences of depression.
Carmina, over to you.
So first of all, I totally agree with Joanna on this, and I think this, the importance of social factors in mental health in general and suicide in particular is very important. Well, in fact, it's overwhelmingly important. And we know, for example, that for every 1% increase of unemployment in a country, there's almost a 1% increase in the rate of suicide. So, and we have been through one of the worst financial crises of basically the century of the last 10, 15 years. So as a psychiatrist and as a mental health practitioner, I really feel that it's an uphill struggle. We are trying to help the very small number of people who recognize they have a disorder, decide to seek help, and accept to be treated. And some of them may even not be helped by the medication that we have. These are still a very, very, very small minority of the people who are unwell and are out there. I mean, we know that only 1 in 6 people in the UK and in Europe on average with depression seek help and is recognized and offered help. And we know that most people who commit suicide, if we want to go back to suicide, most people who commit suicide have not had any contact with mental health at all. So it's very difficult to make a correlation between antidepressant use and improvement in mental health in a population or drop in suicide rates, because we are trying to help a very, very, very small minority of people who are suffering out there. And these people are suffering largely for situations that we have nothing that we can do about it. Financial crisis, wars, terrorism, migration. These are bigger problems that as mental health practitioners we really have to confront, but we have no weapons to tackle.
But it's just one of the. It just doesn't seem to sit right. And I know this sort of the arguments about the differences between medication and psychiatry, but we get a smallpox vaccination and it's eradicated, and then we've got these pills that are called antidepressants. More and more people are taking them, but it doesn't even seem to be having any effect whatsoever. I mean, I know you're saying we're trying to reach out to a small number of people, only able to help a small number of people, but from it doesn't seem that that's even being reflected in the figures either. So I just don't know. I don't know how to square that at all. So
just one point, and then Joanna, I'll stop so you can comment as well. I mean, if you look at suicide rates in the UK, there have been a drop only in the last 12 months. But if in the general population, luckily it's a small drop. But if you look at, for example, the rates of suicide in the over 75, in the older age, there's been a continuous reduction over the last 20 years. So the signal on suicide, if we want to spend more time on that, is not all negative. Now, again, I don't want to claim that this is because of the antidepressants, in the same way that I don't want to use suicide as a way of saying antidepressants are working or not working. But I'm saying there are trends which can be interpreted in both directions, and certainly there are some good signals. In the UK, it's completely different in other countries. For some suicide rates, at least in certain subgroups. But the other things, you made a really important point, which is the smallpox vaccination. The smallpox vaccination is given to every child. It should be given to every child. And in fact, it only works if it's given to every child. So if you're counting the number of smallpox vaccination prescriptions, they are, in the right numbers of millions and millions and millions. So the idea, and of course I don't want to, in any way, I don't think we should prescribe antidepressants to more people. They don't have depression, but vaccination is for people that are well to avoid becoming ill. It's completely different models. So I think that I don't want to oversell antidepressants. I don't think giving antidepressants to people who are unwell can improve the mental health of a whole of the whole country. it would probably improve the mental health of a small number of people in the country, and probably only a fraction of people who take the antidepressants. But for those people, for those individuals whose life is improved, is very important. So we need to try to understand who are these people, how can we reach them?
Right, Joanna, we're going to have to move on. We've already gone over schedule, but I'm going to let you have at it for a couple of minutes. So go ahead.
Just very briefly, really, to reiterate what you were saying. I mean, even if we allow that the effects of antidepressants are very modestly effective over the short term, as demonstrated by placebo-controlled trials, which, as I said, I'm not sure that I believe. But even if we allow that, there's really no evidence that they're helpful to people over the long term. And the long-term follow-up studies that have been done, and they do have their problems, and I'm not saying they're conclusive at all, but they do all consistently show that people who are treated with antidepressants do worse than people with depression who are not treated with antidepressants. They do.
Carmina's not having any of that. Go on, Carmina. Quickly.
So the recommendation is that every first episode of depression, so the first time someone becomes depressed, should be treated for 6 to 9 months. The reason behind this recommendation is that previous naturalistic studies, so basically studies that have been followed up patients before antidepressants were available early on, show that most people who develop clinically significant depression, I'm not talking about transient sadness or normal reaction to life event, but clinically significant depression, they basically end up in bed and they cannot work and they cannot go out. So for these people, depression does not leave spontaneously until after 5, 4, 6 months, 8 months, or 9 months in the most severe cases. So the idea is that the first treatment, you take the antidepressant for as long as it takes for the natural course of the episodes to run its course. Now, we also know that if we stop antidepressant as soon as someone becomes well, so let's say after 1 or 2 months, the antidepressant have helped that person, and you stop, most of them, not all of them, but certainly most of them, around 50 to 60%, will relapse quite quickly within the first 2 to 3 months. So that's the short-term data that supports the recommendation. There have been clinical studies. Now, I agree with Joanna that all the clinical trials that have looked at data, a long-term treatment with antidepressants, 2 years or 3 years, are small and they have their problems. But if you look at just the relapse, so the risk of people of becoming depressed again after they had, let's say, 2 or 3 episodes, once they start antidepressant and they remain on antidepressant for 2 to 3 years, during that time they are on antidepressant, the risk of them becoming depressed again is halved. It's cut in half compared to placebo. In fact, the difference between placebo and antidepressant in the prevention of new depressive episodes in people who have already suffered from many depressive episodes, the difference with placebo is much bigger than the actual difference in the short-term clinical trials at the beginning. So with the limitation that the studies are fewer and smaller, the evidence out there shows that once you have had 2 or 3 severe episodes of depression, episodes in which, for example, every time you have to stop working, or maybe every time you consider committing you consider taking your own life, or your life is completely impaired, well, those people will benefit from long-term treatment, at least 2 to 3 years, in terms of preventing another relapse. Now, and I'll finish with that. The fact that people start an antidepressant and get stuck on it for months or years with no check, with no decision-making about it, that's a problem of implementation of guidelines. And John and I, the only things we can do is to go out there and write about it and make sure our colleagues, both psychiatrists and primary care and other mental health practitioners, do what the guidelines do. There's a difference between consequences of practice that do not follow the guidelines and saying that the guidelines are not good.
Right, okay, we have to move on just for the sake of time.
No, I need to come back on the relapse.
You need to go for it, Joanna.
So I agree that the relapse studies are more convincing, and there's a really, really good reason for that. that if you take someone off antidepressants, and especially if you do it suddenly, and most of them are pretty rapid, a lot of people will get withdrawal symptoms. Even if those withdrawal symptoms are not severe, they'll know that they've been taken off and put on the placebo. And, you know, for a population of people who have got better or think they've got better because they've been taking antidepressants and then they're taken off, that's obviously very frightening. And of course, it's likely to lead to relapse. And indeed, the withdrawal symptoms themselves may be mistaken for relapse too. So I think there's a very good reason why those relapse prevention studies come out showing a bigger difference than the initial studies.
So, right. Should we talk about withdrawal symptoms then? Because I think John.
We are going to get to that. It's going to be the question we're sort of closing up with, which is why I want to rush through these next couple of questions, because I know the idea of withdrawal and long-term use has been a popular issue raised with people on Twitter. I can see some people mentioning it on the YouTube comments, so we will get to it. Firstly, though, I think this is an important question. So under what circumstances do each of you feel it's appropriate to prescribe antidepressants? And I'm particularly interested in your answer for this, Joanna. We'll start with you because of, you know, your critical stance in the first place. So yeah, over to you on that one. Okay,
so I'm, as I said, not convinced that antidepressants are actually helpful for anyone. But how I approach them is that they are mind-altering drugs, and I do think that in some situations a mind-altering drug can be a helpful way of getting through a difficult situation or coping with difficult feelings. So if someone is very depressed and finding that difficult to cope with, I do discuss with them the drugs that are available and the sorts of changes that those drugs will produce. So with drugs like SSRIs, there is evidence that they seem to dampen down people's emotional responses a bit. Similarly, when people stop taking them, they become more emotional, sort of quite tearful. That's quite a typical thing to say, the typical thing that people report. So I describe those effects and ask people whether they feel that they would be useful. I don't, you know, other people prescribe antidepressants. I don't feel, therefore, that I should deny my patients antidepressants, but I try and explain to them what sort of alterations the antidepressants will produce particularly on their emotions and their thinking processes. And some people decide that, you know, they would like to try anything because they feel really, really bad. And that's fine. And then we, you know, just try and monitor the effects of those drugs after they've started them, and you know, making sure that we constantly sort of monitor whether the benefits are outweighing any adverse effects, any side effects they might be getting.
Do you feel any sort of like a crisis of confidence or principles in taking that stance? Because it almost seems like, you know, you're the go-to person when it comes to the critical perspective on antidepressants, and I'm just interested if there's any sort of What worries me is that a lot of people have accepted this idea that depression is a brain disease, is a chemical imbalance. And what that means for a lot of people is they feel that they can't really do anything about it, and they're waiting for a drug to put that right. So part of my discussion with people is also to try and explain to people that actually that's not a well-evidenced theory, and that we are not confident that that's what antidepressants are doing at all, because I think that it can encourage a sort of you know, it can disable people, it can reduce people's confidence and prevent people from developing other ways of trying to manage their feelings, which, you know, I'm not saying that's an easy thing to do. That's often a very difficult thing for people to do, especially if they're starting from a very bad place. But nevertheless, those are the sorts of things that are likely to be more, you know, to have really lasting effects for people. So I do worry, yes, that by giving an antidepressant, even if I'm presenting it in not as a chemical rectifier,
but as something that, might have a mildly altering effect that might be useful and might enable people to get on with their lives, that maybe that's not the message that people are hearing, and it might nevertheless prevent people from doing other things that are more important.
Just before I move over to Carmina on this, what is it that's stopping you from taking like a principled stance in saying that, I've got to be one way or the other about this, and say, well, no, I'm not going to prescribe these to people anymore?
Because as I said, they're widely recommended. They're what people expect to get, and I don't feel that I should be denying people a treatment if they feel that it might be useful.
Right.
I feel that I'm in that situation. I'm there to help them use it safely, and try and maximize any benefits it might have.
Okay, Carmina.
I keep saying this. I agree with Joanna 100% on this. I mean, I may use slightly different wording, but that's probably John and I talk to the patient exactly in the same way. I explain to them that this is is a difficult moment in their life where obviously alone things are getting really bad, and there are clear consequences if they come to me with consequences. As I said, they're unable to leave the house, their family life is going completely down the hill, they're not able to work, and then we discuss the fact that taking antidepressants for a period of a few months, if it's of course a first episode, will allow them to find the energy or the motivation to get through this difficult time and start implementing the changes, or try to implement the changes in their life, which will give the long-lasting effect. Either through psychotherapy or through changes in their life that myself as a psychiatrist and a practitioner working with them could help encourage them or guide them to the important steps to take. I mean, it's semantic, the fact that Joanna may call them mood altering, and I may call them they give you more energy and motivation. I mean, there are different ways of wording it, but I would have exactly the same conversation. I guess I would be more. I don't have any ethical conundrum, because I do believe that these drugs can help the patient. I mean, of course, I don't know until I try whether that particular patient will be helped. And of course, I'm fully aware of the side effect, and I warn them about the side effect. We discuss about the risk-benefit, and the risk-benefit will be different from different people. And sometimes I've had also the opposite situation. I have a patient who asked me for an antidepressant, and I said, look, I think this is too soon. You're really sad because these things happened to you, but it's only happened a month ago. You have your family, you have your friends, you have your life. Why don't we wait for another month and see how it goes? If you manage to go back to work on your own, but then it means we've done the right choice. If in a month's time you're still like this, or things are getting worse, we will consider antidepressants. So I sometimes, and I'm sure Joanna has the same experience, sometimes we as practitioners tell patients that we want to wait and see how things are going. And it's a discussion that we take, as a decision that I take together with the patient, and based on what their preferences are. And I really think we're talking to this patient in the same way. I may be a little bit more convinced about the biological evidence. And I think that it's very important, I agree with Joanna, that we do not disempower patients. But that's a problem that all doctors have. So if I have a patient with diabetes, I mean, not me obviously, but if a diabetologist or a GP has a patient with diabetes, they wouldn't just prescribe a drug for diabetes and say, but don't worry about the rest. Eat as much as you like, don't do any exercise, don't change any of the health habits, don't eat more vegetables because you're taking a medication. They would also help the patient make the changes in their life, which would then either help the medication or potentially help the person stop the medication at some point. And with depression, it's exactly the same. You start with a support that helps patient to mobilize the energy to try to change things, and we help them to change things so then they can stop antidepressant. They don't relapse again because there've been changes in their life. So I agree with Joanna, we should tell them that this is just a support. It's not taking the depression away, it's helping them finding the right solution. And if there is a risk the patient feel disempowered, then we should definitely be out there and explaining to people that this is not what antidepressants are for.
Okay, moving on. So, be nice and sort of concise with this one, I think, but I'd be remiss if I didn't bring it up. So I don't want to keep picking on this study, but it was the big one that came up at the beginning of this year and everyone was talking about. So again, with the Cipriani study, it was 522 studies in the meta-analysis. And according to, I got this from Bob Fidderman's, I think I'm saying that right, from his blog, something like 78% of the studies were funded by drug companies. So that sort of begs the question, common accusation about the influence of big pharma on the propagation of antidepressant use. So I'm just interested in maybe tackling a couple of what you think are sort of maybe the reasonable and unreasonable common accusations. Start with you, Joanna, if you could.
Yes. So I'd like to link this to my response to Carmina's previous point, because I think, you know, one of the biggest influences of big pharma has been to spread this myth that depression has been shown to be due to a chemical imbalance, and that's what antidepressants do. They put that right. And I think that I think that an awful lot of people are now convinced that that's true, or have become convinced during the early course of their treatment. And so for me, you know, when you're talking about possibly treating someone with antidepressants, the first thing is to disabuse them of that myth. And I think that I think that rates of antidepressant use would go down, at least to some extent, possibly quite considerably, if people understood that was not supported by evidence, and that antidepressants were not putting right a chemical imbalance, but were causing some alterations, some subjective alterations, like a numbing of emotions, which some people might find useful, but a lot of people don't like the idea of being in that sort of state. So pharma was very influential in promoting this idea, and it was, I think the fact that it's caught on so widely shows how appealing it was and how easy it was to market, but also how heavily marketed it was. What else did you want us to say about pharma? Yes, they funded a lot of the research, not quite all of the research on antidepressants, though.
Well, I think another one of the common accusations is that maybe GPs, doctors, they're just sort of shills for the pharmaceutical industry. They're just sort of, the salesmen out there just giving out antidepressants willy-nilly. And again, it's a common accusation, but is there any basis of truth in it?
Well, I mean, yes, there is. Pharma has a huge marketing machine and does bombard doctors with literature and advertising. And the advertising campaigns in the early 90s that established SSRI use and really set off this increasing use of antidepressants were very, were extraordinary. And what else was I going to say about that? I can't remember.
Well, hand that over to Carmine and give you a chance to think about it.
So the first point that I want to make in response to the Cipriani paper is that they actually show that there is no difference on whether or not the trial, so the study was funded by a pharmaceutical company or not, in terms of the efficacy of antidepressants. So what this shows is that the trial, the studies in itself, including data that have never been reported before, were not basically, manipulated by pharmaceutical companies to have a better results. Okay, so that's one point. So the point of the role that the pharmaceutical company had in the past about spreading the notion of depression as a chemical imbalance and antidepressant reversing it, I agree with Joanna that they've been instrumental. And the results has been, if you like, a simplified model becoming the only narrative to explain depression. Now, I still think, and the evidence is there, that even if there is no even if we cannot measure a chemical imbalance per se, there are measurable changes in the brain, and we can discuss what does it mean, the changes in the brain, but there are certainly things that changes in the brain of the depressed patient, and at least some of these changes are either changed again or brought back to normal by antidepressant. But the key thing is that, that's something which happened in the past. Now, all of the antidepressant prescribed but one, or perhaps two, but I think it's one, certainly all the most famous one, are off patent. And pharmaceutical company not only don't care anymore about selling those antidepressants because they don't make any money, they don't care about making new antidepressants. So we are kind of stuck with the drug that we have. So the hope to find new drugs which have less side effect and are more efficacious is gone, because these drugs the pharmaceutical company are not interested in developing new medication. So whatever happened in the 80s and in the 90s, and certainly there was a very strong commercial push and a very strong advertising machine, as Joanna said, today is not relevant anymore. And I think doctors prescribe more antidepressant and people accept more antidepressants, not because of pressure from pharmaceutical company. It is coming from being more aware of the disorders, being more aware of what depression is. We think there's an element, I certainly think there's an element of a positive element about it. It means people feel less stigmatized and prepared to seek help. In this context, we should certainly help having the right understanding of depression, not in a way that disempower them, as Joanna says, but at the moment, pharmaceutical company input in the prescription of antidepressant is zero.
I'm just wondering whether, the fact that pharmaceutical companies aren't producing any more drugs is because they don't need to. It kind of seems to me that maybe, like you were saying then about the advertising and things like that, maybe it's just become this idea of the chemical imbalance has become so sort of ingrained in the social zeitgeist that it doesn't need advertising anymore. Like Coca-Cola, everybody knows about it.
But they don't make any money anymore. So it doesn't matter whether it's ingrained or not, because they are not making any money anymore from antidepressants. It's not that they have a message out there at the pocket, the money is still coming in. They don't make any more money because they don't produce, they don't sell them anymore because they're all off patent.
But nevertheless, their previous activities have changed the way that we think about ourselves. So sociologist Nicholas Rose described how this huge antidepressant advertising had created neurochemical cells, people who put their emotions and their feelings and what was happening to them down to their brain chemistry, rather than thinking in terms of themselves as a whole person in a social context. So, yes, I agree with Carmina that the pharmaceutical industry are not very active, especially around antidepressants at the moment, not really in the whole mental health field at the moment. But their previous activity has fundamentally changed the way that we think about depression, and has undoubtedly been at least partly responsible for this huge escalation of antidepressant prescribing, I would say.
And I agree. And I think obviously they did it for the money, so because that's their commercial company. I think, and if some of it has been about educating and talking about depression and destigmatizing it. Maybe it was not even what they wanted, but if one of the unintended positive consequences is that more people have been talking more about depression and feel less stigmatized, I think that's a potential positive consequence of that effort, that we now need to make sure we reframe and we explain to people what depression is.
I'm just before we close this up, I'm confused about this idea that pharma don't make any money off antidepressants anymore, because the market and prices are based on supply and demand, and there's plenty of demand for it. And you've seen this in cases of places in the pharmaceutical companies in America where they're sort of they're messing about with the prices, like the EpiPens and then the Martin Shkreli case and things like that. So who's making the drugs? And I can't quite buy the idea that the pharmaceutical companies are just doing this as some sort of charitable endeavor and not making any profit. I don't know where, if there's no profit incentive, I don't understand why
pharma makes its main profits from new drugs that are under patent. And when drugs go off patent, it doesn't make very much money on the drugs, partly because generic companies can start coming in then and manufacturing them.
Well, that's sort of the distinction I wanted to make, because so when Carmine said that they're not making money off it anymore, you know, there's a difference between, you know, maybe they were making billions at one point and then that's gone down to millions, but are we talking zero, or are we just talking less money being made?
I mean, I'm not an expert in the financial market. My understanding, and Joanna, I don't know if you can help me with that. My understanding is that most antidepressants, certainly in the UK and Europe, are now made and sold by companies that do generic. I mean, there may be a small amount of market still with pharmaceutical company. I mean, when I'm talking about pharmaceutical company, I mean the big pharmaceutical company that originally developed. Of course, you know, the small company in India that is producing Prozac today and selling to London, there's also a pharmaceutical company. It's a small company in India. It's not big pharma. And I think, seriously, I don't think they make any money. I mean, whether or not they're even selling it, I don't know. It may be different from different companies and different products, but I think we're talking about a very small amount. Certainly nothing that you know, they're not putting any input in selling it because they're not making any money out of it. I mean, Joanna, I don't know what you think with that.
Yes, yeah, I would agree. I mean, there's really no big marketing around antidepressants at the moment.
Right, okay, moving on. So I think this has probably been the most sort of in demand topic around this from Twitter and from YouTube, and it's talking about like the risks, the side effects, and long term. The thing that's sort of interesting for me around this is you've got a lot of individuals who sort of swear by antidepressants, and it changed my life, it saved my life, whatever. But those opinions seem confined to individuals, whereas the people that are against antidepressants, the people that have had a bad experience, who feel like it's ruined their life, they've spawned entire movements. You know, there's activist groups, there's bloggers, there's podcasters, YouTubers, and I think there's even some charities around that. People that feel that they've had their lives destroyed by antidepressant medication. So, yeah, if we could just sort of move into that realm, I'm interested in the risks and the side effects, and particularly long-term risks and side effects, because again, this isn't something that looks like it's being studied with all these the studies that show antidepressants in a positive light are all confined to 8 weeks in length. So yeah, Carmine, start with you on that one, please.
Okay, so I mean, you asked many questions altogether.
Yeah.
So let me first go back to the issue of the side effect and the long-term use. Well, actually, let me first by starting by saying that, you know, I don't think it's fair to say that the patient had a life-saving experience are some kind of minority, and the patient
I didn't say they were a minority, Carmine. I said that they don't spawn movements. There's not an advocate movement for antidepressants the same way that these groups of people that have got together and said that this stuff has destroyed me.
Of course, and I think for me, and I was discussing this on Twitter with Bob Fidelman, in fact, earlier today. For me, having access to the experience of patient, the most, especially the patient that has suffered more and they've been more vocal about it, has really opened my eyes about the fact that there's certainly a personal experience of patients out there that doesn't fit with our full understanding of antidepressants, side effect and risk, and certainly has probed us to think about how can we transform those individual experience in research that could then inform us our clinical practice. So my heart really goes to the people that have such a severe side effect, and their relatives, and I really hope that we'll be able to capitalize on this individual experience to try to understand this in a more science-based or research-based way. And I think, of course, people have bad experience will be vocal, and rightly so, especially because if they feel that their experience has not been recognized or has not been acknowledged by the clinician. I think, that's changing now. And that, for example, there are initiatives from the led by the Parliament, led also by the British Medical Association to look into withdrawal effect associated with antidepressant and a lot of other classes of drugs. I mean, we shouldn't forget that antibiotics give withdrawal effect, medication for blood pressure, medication for gastric problem give withdrawal effect. It's every time you stop something which has been in your body for a long time, it will give your body and your brain will react with it. So I think that's very important. So sorry, I know it was a long spell, but I think I want to acknowledge the importance of what this individual experience are telling us and how we can transform that into research. Now, the big controversy, I think, is the difference between withdrawal symptoms and relapse. I think that it is well documented that, in fact, quite a lot of patients have withdrawal symptoms, as in their symptoms that starts quite early, within 1 to 2 days after they stop antidepressant. And the guideline would say the most patient, I mean, it's difficult to define what most means, 70% or 80% or 90%, but let's say most patients will experience symptoms that are mild or transient, or that, they may even be severe, but they self-limiting and they improve spontaneously within 1 to 2 weeks. For patients for which, and these symptoms are varied, they include anything from headache to nausea, to sweating, to tingling sensation, to more agitation and irritability. So, there varies anything from purely physical symptoms to more emotional symptoms. We have guidelines to try to help people with this. I mean, of course, the most important guidance is never stop antidepressant abruptly. And the problem is that, unfortunately, people sometimes stop antidepressant abruptly because they decide to stop and they don't come back to the doctor, or they do it without telling you or without discussing. I think the guidance is very clear, even for a minimum, antidepressant should be slowly withdrawn over 4 weeks. That's the minimum. I suggest, well, not only myself, but many doctors and the guidelines suggest for people who have been for quite a long period of time, maybe stopping over 2 months or even 3 months with a slow reduction. And if the symptoms appears, maybe bring the antidepressant back at a lower dose and keep it a little bit longer, and just slowly stopping the antidepressant. So certainly the most important recommendation is this: slowly stopping the antidepressant. Now, are there people for which this is becoming impossible? They've not been able to do it. The side effects have been really overwhelming. Of course there are. They're rarer. I'm not saying they're rare, but they're rarer, and we certainly don't have enough data, or not the same kind of data that we need on them. But there is more, we're listening, and people are doing research on this at the moment.
Okay, Joanna, over to you.
Yeah, so I think we need to distinguish the side effects, or I don't like that word because it implies there's a therapeutic effect, which I would question, that's distinct from side effects, but the adverse effects of antidepressants that people experience while they're taking them from withdrawal effects. And for both of these things, we need to also consider the different antidepressant classes separately, because they have a different range of effects. So thinking about the SSRIs, relative to lots of other drugs, the side effects that you get while taking SSRIs are generally pretty mild. There are some more serious complications, but they're thankfully rare. So for most people, the side effects that people get while they're taking them will be fairly mild. One of the most common side effects is sexual dysfunction. That's been recognized for a long time. Now, the more worrying thing about the sexual dysfunction is there's a little bit of evidence coming out, mostly from the sexual health literature, that in some people that sexual dysfunction might persist after they stop taking the medication. Now, to me, this is a huge, huge issue. I don't know why there aren't huge multi-million-pound research grants to look at this, because even if 9% of the UK population are taking antidepressants, and many of those will be taking an SSRI, and even only a small proportion of those people are going to get persistent sexual dysfunction, that's still a big problem. So that's one thing. Now, coming back to withdrawal symptoms, one of the reasons people are angry about this is it's happened before. The withdrawal symptoms related to widely promoted, widely prescribed medications have been ignored in the past, as in the benzodiazepine scandal. And it only emerged in the 1980s that these things were associated with what could potentially be a very difficult withdrawal syndrome, whereas they'd been marketed in their early days as being non-addictive, much easier to get off than the predecessors, which were barbiturate type drugs. The same thing happened in the early 90s. The antidepressants were marketed as being non-addictive, different from benzodiazepines. You don't have to worry about about the same sort of problems. And then, of course, it does become apparent that getting off them is not always easy, that there is a withdrawal syndrome. And indeed, as Carmina was saying, that for some people, it seems to be a really difficult experience. We don't know how many people that affects, but certainly it seems to apply to some people, with some of the agents more than others, mostly with the agents that act, that have very short half-lives, that are eliminated from the body very quickly, so the withdrawal is more intense, like paroxetine and venlafaxine are particular culprits. So I think people, I think it's understandable why people are angry about this. It wasn't, once again, the same mistake was made. A drug was pushed onto the population as being safe and non-addictive, and it turns out that actually it is associated with withdrawal problems that can be really difficult for some people.
Right, okay. So we're going to need to sort of wrap this up now and get to the Q&A portion. I guess one good question to sort of finish off with would be just from each of you is whether you think that antidepressants provide a bit of a cheesy term, this, but provide a net positive benefit over a negative. Is there more benefits than pitfalls to antidepressants? So start with you, Joanna.
Well, I'm not convinced that they have any benefits at all, so I don't think they have any net benefits. Quite simple, straightforward answer for you.
Yes. Carmina?
If prescribed in the right patient, in the patient who really needs them and whose life is impaired by depression, then yes, there's a net benefit.
Right, okay. So let's move into the Q&A portion here. So I don't know. I'm not going to sort of pick these based on what I think are particularly interesting to me. Left this up to you guys on Twitter. It was up to you to submit your questions and vote up the ones that you wanted to be answered. So I'm just going to sort of work my way through them. So starting with the most popular one here. This is from Nora Lint. It says, if every 10th person in the UK is taking antidepressants, and antidepressants induce a psychosis in every 100th to 1,000th person, there should be between 6,500 and 65,000 people with antidepressant-induced psychosis in the UK. Could you discuss? So, Carmina, take it away.
I mean, the definition that she brings is probably, the number that she quotes is probably related to the fact that the frequency of side effect of any medication, including antidepressants, are classified based on whether they are frequent or less rare or very rare. I mean, antidepressants can induce psychotic symptoms. They can induce what we call manic switch, so they can induce manic symptoms in some predisposed people. So do many other drugs. I mean, we know, for example, that Lariam, which is a well-known antimalaric, and other medication that have psychiatric side effects. These are rare, but it happens. And I think, when patients develop a psychotic episode, the first thing we would ask is, are you on any medication? And try to understand whether that medication has caused the symptoms. I think that it's the same risk that we're having for every medication. All medication can have side effects that are behavioral, that affect our brain and emotion. Some medication are more frequent than others. When is the case, we'll make a diagnosis when we assess them.
Joanna?
I'm actually not convinced that antidepressants cause psychosis. I think the evidence is very difficult to interpret on this, or that they cause a switch to mania. What they do cause is intense agitation and activation in some people, and that seems to be a more common response in younger people, and may be linked to again the controversial area of whether they increase suicidal thoughts and suicidal behaviours or not. But I'm not sure. I certainly don't think we can be certain that they cause psychosis.
Right. Okay. Question from Bob Fidderman. Given SSRIs are not safe for children and teens, will Carmina, or indeed the Royal College, ever condemn those practitioners who prescribe off-label to children and teenagers?
I don't speak on behalf of the Royal College, obviously. And I'm not a child psychiatrist. I mean, there are definitely serious problems with prescribing antidepressants to children and adolescents. I think individual cases, the risk and benefit are always at the population levels, and certainly at the population levels, the risks are very high. Whether or not individual cases may benefit from antidepressant, but they require a very intense monitoring, I don't know. It's certainly something that needs to be done under proper, close supervision from an expert clinician.
Okay, seeing as we're addressing individual people here, Joanna, okay, this is from Sameh Huda. So he asks, given that antidepressants are equivalent in effectiveness to, for example, CBT, even after controlling for effects of drug company trial sponsorship, does this mean Joanna says she should not offer either psychotherapy or antidepressants for depression?
So this gets us into sort of broader philosophical questions about what we think about, what we think depression is and how we should approach it. And I don't think that it's helpful to approach depression as if it is a single disease, a single brain condition that people have. I think depression is a human response to usually a negative situation. And we need to help people to deal with the particular negative situation that they find themselves in. So I actually don't think we should really be approaching it as something where we find a particular treatment and then we roll out that treatment to everyone who we think has this condition. So that would be my response. So I think in some people, some sort of psychotherapy may be helpful in order to help them unpick what's been going on for them, and try and help them to develop some solutions to it. But I don't think it's going to be helpful for everyone at all.
Right. Okay. From Anne Marcos, if antidepressants are successful, why are more and more people on disability and long-term illness? Why are people prescribed a drug that is designed for short-term use now using it for the rest of their lives? Carmina?
There are two different questions, and I think we've partly addressed those. The fact that people are on disability, or unemployment, or benefits, or commit suicide, or take their life, this is mental health at the population level, to which prescription of antidepressant, unfortunately, is not going to make this seismic shift, just because we said that, it's not in our power, unfortunately, as mental health practitioner, to help people as much as we wish we could help. And as Joanna said, depression is, the consequence of disruption in the relationship between an individual and the social network and society, and changes in, usually in association with negative life events, and these things happen. So I don't think we can expect antidepressant to change society. And the issue of the difference between short-term and long-term, so these drugs, it's not that these drugs were designed to be used short-term. Most studies are short-term because that's what the pharmaceutical, what the bodies that have to approve pharmaceutical drugs require short-term trial. And then, of course, pharmaceutical company or other investigators have conducted long-term trials, as we were discussing before. And now there's basically published studies of around 2 to 3 years for most antidepressants, if not all of them, most antidepressants, showing in people who have had more than one episode of depression, especially if they're severe, showing that they reduce the rate of relapse. And we can talk about the difference between relapse and withdrawal symptoms if you would like to do so. So if people get stuck for life, as this person says, and if it happens just out of inertia because the doctor doesn't really change it and things is not really monitored, that's a wrong implementation of the guidelines. And as I said before, we should go out there and educate practitioners and educate the population about this, but we cannot blame the guidelines if they're not being implemented properly.
And can I come in, Danny? Is that all right?
Yes, of course, yes.
Yeah. I think this is a real problem, that more and more people are ending up stuck on this medication for years and years. This is what the data clearly shows. And that's despite the fact that we know that most people do not want to take long-term medication. Most people really don't like that idea. So most people will be wanting to or trying to come off medication if they can. But I think there are a number of reasons why people get stuck on this medication. And one is, that they may try and come off and experience physical withdrawal symptoms and actually just find it too difficult to do. And another reason is I think people can become psychologically dependent or, feel very vulnerable and be too anxious to actually have a go at stopping. And both of those things, I think, actually we need to help support people more to get off if that's what they want to do and if there's really no need for them to be taking the medicine anymore.
Can I just say that I agree 100%. And I think one of the issues that as doctor we need to discuss with the patient right from the beginning is that we hope that in 6 months, 9 months, 12 months, we will be able to start stopping this antidepressant, and we'll monitor the situation at that time. So reassure them right from the beginning that this is just a specific amount of time. Of course, we will be guided by how things will go in the future, but make sure that message is there. And I think every patient should at least consider and be supported in an attempt to stop antidepressants, unless, of course, they already tried many times and they always become depressed again. But otherwise, especially if people only had 1 or 2 episodes, there's really no indication for them to be stuck on antidepressants on life. And if they do experience side effects, which they will, hopefully most of them will also be able to go through just with support or with more guidance. But I totally agree with Joanna, we should encourage people to go back to the doctor and discuss, do I still need to be on this antidepressant?
Okay, another one from Bob Fidderman here. This for you, Carmina. Says there were 20 adult suicides in paroxetine clinical trials that we know of. Does Carmina still think paroxetine should still be prescribed with the knowledge of these 20 adult suicides?
Okay, I'll be honest with Bob. I don't know the data that he's referring to, as in I haven't seen them. However, my view on paroxetine is that it has probably one of the worst side effect profile. It's one of the worst withdrawal symptoms profile. It doesn't have any particular benefit over the other. So, I mean, as a clinician, I don't use it. unless I know that that particular patient only responds to paroxetine and wants paroxetine and just use it before successfully. So I think, that's my view on paroxetine.
Okay, one from Fiona French. I like this one. You probably go deep. Probably do a whole episode on this one. It's why are we still debating this subject decades after antidepressants came to market? Surely the evidence should be clear by now. Joanna?
I suppose for all the reasons that we've covered over the last hour and a half, that the differences between antidepressants and placebo are small, that whether it's useful or valid to consider depression to be a disease that is likely to respond to a chemical treatment is controversial, and people have different views on that. It's not, it's not straightforward. It's not like having an episode of pneumonia where, yes, it's obvious there's something wrong with your lungs and it's probably going to be a good idea to try taking some antibiotics. And I think also to say that, yes, some people find antidepressants to be useful and get better fairly quickly, but an awful lot of people actually take antidepressants and they don't seem to be terribly useful, and they're still depressed, or they're depressed again at the end of a year. That's what the big STAR-D study in America showed. So there are an awful lot of people that actually, the experience doesn't match up to what the evidence is saying about how useful these drugs are.
Carmine, anything to add?
I think there is also one more element to consider, which is that, psychiatric mental disorders, mental health problems, psychiatric disorders will always raise strong emotions. And I think that's part of the fact that we're debating it so much is because, we're talking about emotions and behaviors. And as Joanna would, correctly say, we're talking about the interface between the mind and the brain and the body. And these are things that tap into the philosophy of what does being a human being is. And I don't see anything reductionist about saying that all of my emotions and behavior and memory and the things I love and the things that make me sad, the things that make me happy, they're all in my brain. I don't find that reductionist. I don't find that this is making me a lesser person, but that's my view. And other people may feel actually that all this complexity can only be justified by the existence of a supernatural or kind of a soul, and some people may have some kind of intermediate, position. I think these are important questions. That's why we're debating that.
I'm just reading Fiona's response on YouTube there. She's not impressed. She just said if the evidence was clear, it would be clear by now. So, okay, we've got another one from Bob Fidderman, dominating the questions. I'm not showing favoritism. His questions are the ones that are getting the most likes.
Hey, Bob.
Can Carmina please provide a tapering guide for patients, and please state for the record who devised the tapering guide?
I can show you the one is on my desk. This is the prescribing guidelines from the MOWE. And they say 4 weeks minimum for every antidepressant. You usually do this by tapering down to a quarter of the dose every week. Longer if needed. That's the minimum. Longer if needed. And there are, of course, some antidepressants are worse than others, and so you cannot make a unique recommendation on all of them. But certainly, as a minimum, 4 weeks.
Sorry, Joanna, go ahead.
I'm involved in a research project being run from the University of Southampton, which is developing a web-based program for GPs to cover lots of different withdrawal scenarios. So it has a relatively short taper over a couple of months, but it also has a much longer taper for anyone who finds that difficult or who has had previous difficult experiences withdrawing. So I think there is work going on to try and come up with guidance help people taper and to help people, you know, do that with the minimum problems.
Right. Okay. Right, I'm going to cheat here a little bit, and so this was a question that was this was submitted during the antidepressants Mythbuster last year, and it was one of the highest voted questions, but it didn't make it in. I think it was submitted by Lucy Johnston. So, and I think it's relevant here. She said that the highest prescribing levels for antidepressants are in the UK's most deprived areas, but don't lead to less depression. Surely this implies social, not medical causes. Carmina?
I mean, I agree, but I don't think that these are not two mutually exclusive models. Depression is driven, but it's partly driven by, well, it's mostly driven by societal factors, because other life events are driven by society, so unemployment, poverty, discrimination, or because when you have a private life event, let's say you have a bereavement, society will either support you or will not support you, or you will be more integrated or not. So all of these factors are very important. So of course depression is largely a societal issue. This is not, nobody's questioning this, but you know, obesity is a society issue. Diabetes is a society issue. High blood pressure is a society issue. Society contributes to any cancer. You know, we're living in London, one of the most polluted cities. You know, if you look at the data in Europe, you know, cancer is a society issue. So society is everywhere. That's different from saying, can we help at least some individuals by prescribing antidepressants? As I said before, we're not going to remove depression from the streets just by giving antidepressants. Of course we're not.
I think it's really obvious if you work in a socially deprived area that the depression is related to socioeconomic factors, that unemployment, divorce, you know, housing issues, increasingly benefits issues, drug taking, crime, violence, gangs, all those sorts of things. And for me, the problem is that, you know, if you then give people antidepressants, you're almost saying that you have no right to be depressed. You know, it's not normal to be depressed in this situation, and you know, just take this and this will numb you a bit, and you won't have to worry about it. Well, they should be worrying about this situation because it's, you know, and that situation needs to change. Not that the individual can necessarily change it, and of course that's often why they're there in your office, because they are fairly helpless. But we need to be tackling these problems at a social level to, you know, to support people to prevent them ending up in psychiatrists' offices in a very poor state.
Well, sorry, Danny, but these are not mutually exclusive things to do. You know, no, please let me say this, because I think, you know, we can be socially active, even politically active, and try to change society, protect the people that are most vulnerable, you know, make sure that the society in the UK or everywhere is aware of vulnerabilities and protect the people that are most vulnerable, and then vote for the, you know, make the, you know, our political decision based on that. And at the same time, help the individual person that can no longer go to work because of the depression to try to go back to work with an antidepressant, and then perhaps make, you know, have the energy to try to make some change in his or her own life if possible. So I don't think, if there is any perception that by giving antidepressant we're telling people that, you know, there's nothing they can do about it, and this is, you know, this is perfectly, you know, there's just, they have an illness, they don't have any control, then I think this is the wrong message, and we should be able to give antidepressant with the right message next to it.
Well, it was on that note, on that same idea of mutual exclusivity. So yeah, Lucy Johnston's watching on YouTube now, and she's put, Carmina says they are not mutually exclusive causes. Well, maybe in this case we can admit there is lots of evidence for social causes and none for biological causes.
But these are not, sorry, I know that if I interrupt you again, these are not mutually exclusive. The biology is the mechanism through which society changes emotions and behavior. So if you have a car crash, the biology is that your bone breaks. That's a biological thing. Your bone breaks. The society, the fact that you were maybe drunk, or the car was not working, or there was traffic, that will drive the accident. The bone breaking is biological. That's the same thing. Society put the pressure on an individual. The brain change with this pressure, and the emotions, the behavior change with it. The same way that the brain change when we are happy. If we fall in love, something change in our brain. When we get, a success at work and we feel happy, something change in our brain. These are the mechanisms through which society change our emotions. Not change, influence our emotions and behavior. They're not mutually exclusive. It's not a biological cause unrelated to society. They're all mechanisms. They're all on the same path. Society, individual, biology. They're all linked. And this is not reductionist. That's the whole point. I don't see this as saying that the human being is less complex or less beautiful because there is a brain responsible for that. In the same way that, we put our life in our heart. We always thought that the heart is the base of our life. Well, there's nothing wrong. There's nothing wrong in saying our life is in our heart. That's biological too. Yet it's the place where we feel love. I think it's the same.
But this is why it's really important to say that we don't know what biological stuff is going on when people are depressed. And antidepressants, we have no evidence that they're actually doing anything to affect whatever it is that's going on, if indeed it's just the one thing that's going on. So, it sounds nice and sort of sequenced, as if, we're dealing with the chemical fallout of social events, but actually we've got no idea that we're doing that. We're just giving people these chemicals that make them feel a bit different.
But they feel better. Some of them, a little bit.
Right, okay, folks. So going to wrap this up in a minute. Just two final questions. So this one's for you, Joanna. Again, this is from Sammy Huda. I don't know if I'm pronouncing that right. Apologies if I'm not. Would Joanna suggest we stop using other medical and therapeutic interventions with effect sizes less than 0.5, her suggested threshold for effective intervention? Does she realise this would mean banning a lot of effective interventions and lesser health outcomes? He's used some sort of symbols in the question, but...
the effect size relates to the measurement, the measuring instrument that you're using. So I'm saying that the effect size translates into a very small difference on the depression rating scale score, which is almost certainly not clinically detectable, let alone helpful. And so that's why I'm saying in this particular case that the antidepressant effect size doesn't add up to a clinically worthwhile effect. In other areas, the effect size might represent a difference on a measuring instrument that might be worthwhile. So you can't just use effect size, apply one effect size across lots of different areas. I think that was the gist of the question, wasn't it?
Right. Okay. And final question, one from me that I'm interested in, and that is, what kind of evidence would have to emerge for each of you guys to sort of concede defeat? I don't know if that's quite the right way of putting it, but to say, for Joanna to say, oh, well, actually, it's, it's primarily a biological issue, or for Carmina to say, well, actually, biology's got nothing to do with it. It's purely a social issue. Start with you, Carmina.
I just want to say this. I don't think we can say something is only sociological issue. The society creates the condition for depression. For people to feel sad, something must change in the brain. The same way that for people to fall in love, something must change in the brain. For people to feel happy, something must change in the brain. Either is the brain or there is a soul. Something has to change. The two things are not mutually exclusive. That's, they're the same thing. So, I think I don't need to be convinced that society is important. I'm already convinced. Joanna is already won. I'm already one of her fans. There's nothing else that she needs to convince me.
Joanna?
Well, I'm also not completely happy with distinguishing it in that way. because I think actually the problem is even deeper. I think it's not just whether depression is caused by social things or caused by biological things. I think our conceptualization of depression is wrong. I don't think it is a thing that is in any way similar to a disease or medical conditions. I think it's as I was saying, a human response to the environment. That obviously varies between different human beings, and some people therefore struggle with depression, depressed feelings more than others. But I just don't think it's useful to see it as a thing that is caused in a sort of simple mechanical way. We know that there are some situations where people who are depressed and have depressive symptoms turn out to have brain diseases. That does happen. And it may turn out that we discover new brain diseases that are causing some cases of depression. That's quite possible, but I don't think that we will ever be able to. I don't think we'll ever find a specific biological driver of depression more generally. Which is not to say that there aren't things going on in the brain when people are depressed. There, of course, are, but I don't think that it's right to think of the biology as driving it. It's more a correlation, and it's probably a much more varied situation than we often allow it to be.
Right. Okay. Well, guys, we've done the 2 hours. We made it. No technical hitches, got there in the end. And no, there was no filibustering, there was no fighting, there was no name calling as well. That's good. That happens a lot on Twitter. So yeah, for me, the goal of this was to sort of raise the tone of debate, raise the quality of debate. I know social media, it's got its uses, but I don't think the quality of debate, especially from a service user perspective, on places like Twitter, is very productive. And so that was the goal for me doing this, the idea that we could get, 2 people that were sort of to an extent ideologically opposed to just sit down and have a civilized conversation. And I think we achieved that. And yeah, I'm chuffed. I'm chuffed how it went. Have you guys got any sort of closing statements you'd like to make?
Just to thank you to Carmina for debating with me. Most people won't, so it was very enjoyable and helpful. And I hope it's been. I hope we've managed to show that there are different positions on this subject, and they're both thoughtful positions. People have put thought into them, and you can make a case for both.
Carmina?
Absolutely. I want to thank Joanna and, of course, you for organizing this. It's been extremely wonderful experience, and I think it shows that within the broader mental health communities, both scientists and practitioners, there are different opinions, but those can be discussed together, and ultimately we all want just the well-being of the patient, and we're trying to pursue it in different ways.
Okay, well, yeah, I enjoyed it. Thank you for everybody that's submitted questions and got involved on Twitter, whether, even the people that were slagging it off. Thank you to you as well. Thank you to the people on YouTube as well, sort of helping me come up with questions throughout the debate. I do plan on making this a regular thing, different debate topics, and bringing in people from, let's say, different sides of the ideological aisle, and making this a regular thing, live debates with audience Q&A. Got to thank Andre Tomlin from Mental Health. I think he gave us the final push that we needed just to get that last little bit of interest and make it worthwhile doing. Thank you to you guys for doing this as well. It's been a privilege, especially for me with this little podcast. I've got my tiny little corner of the internet. I've managed to get the 2 of the top people in the field to come together and have a civilized debate. So yeah, I'm chuffed with it, and we'll do this again in the future sometime. So thank you to you guys. Thank you to the audience for watching. We'll see you later.